Briefly look at the other important cause of QRS widening. What is the other important cause of QRS widening? Yes? So before we go, we'll pre-excite you, right? So that you go with some excitement. So this is a pre-excitation syndromes. So here what happens is, in addition to normal conduction system, we have certain additional fibers which connect the atrium to the ventricle. So these are called accessory pathways. So are called accessory pathways. This can happen as a congenital abnormality, or it can happen associated with the congenital heart disease. Certain congenital heart disease may be associated with the accessory pathways. So there are three known accessory pathways. One is an accessory pathway which connects the atrium to the ventricle. From the atrium to the ventricle, bypassing the AV node. So this is the commonest of the bypass pathways or accessory pathways, which is called Kent pathway. The Kent pathway connects atrium to the ventricle. Then there is a pathway which can connect the atrium to the bundle of His. It can connect the atrium to the bundle of His, bypassing the AV node, but it connects the atrium to the bundle of His. This is called James. And third pathway is the one which is going to connect the atrioventricular node to the ventricle, from the node to the ventricle, or vesicle from after the node, from the vesicle for the bundle of His to the ventricle. Instead of normal conduction system, there is another pathway which can connect from the His bundle to the ventricle, which is called Meheim. So these are the three important pathways: Kent pathway, James pathway, and Meheim pathway. Atrioventricular, atriohisian, Hisian ventricular, or vesicular ventricular, or Hisian ventricular are the three pathways. So it is very easy to diagnose what pathway by looking at the ECG. From ECG itself, you know which pathway you are dealing with, right? Here, for example, you see that very importantly, because my AV node is bypassed, what will happen to my PR interval? PR interval will be short. So once this is bypassed, subsequently this vesicle or this accessory bundle connect to the muscle here. So no longer it is connected to the specialized conduction system. Although the impulse coming rapidly to the ventricle, subsequently it is going to conduct through the muscle. So the initial impulse comes rapidly to the ventricle, then it conducts very slowly. That's why you have a slur initially, which is called delta wave. So whenever I have a short PR interval and initial slur in my QRS, I know it is atrioventricular accessory pathway, which I call them as WPW syndrome. So here what happens is, I have a short PR because my AV node is bypassed. Subsequently, my conduction is through the muscle, which will produce the initial widening of QRS. This is what the ECGs I told you: short PR, initial slur, which is called delta wave, terminal sharp QRS complex. So whenever my PR interval is short and there is a delta wave, I know it is a Kent pathway. It is a WPW syndrome, Wolff-Parkinson syndrome, when it is associated with tachycardia. The syndrome you call it when there is an episode of tachycardia. When you look at the ECG alone, patient does not have any episode of supraventricular tachycardia. You call them as accessory pathway, not WPW syndrome. WPW syndrome is given once you have demonstrated episode of tachycardia. Right, now look at here. Here my AV node is bypassed. After that my conduction is normal. Isn't it? My pathway is bypassing the AV node, then connect me to the bundle of His. Subsequently, my conduction is going to go through the specialized conduction system. So no longer here I will have a white QRS, isn't it? No longer I have a white QRS because my accessory bundle is not connecting to the muscle, it is connecting to the specialized conduction system. So here the AV node is alone bypassed. I will have a short PR but normal QRS complex. So I have only normal QRS complex is normal. There is no initial slur, there is no terminal slur. QRS duration is not 8 seconds. My PR interval alone short. So that means I know AV node is alone bypassed. So this is a James bundle. Whereas here, my AV node is not bypassed. Isn't it? Up to this time, the impulse is coming through the AV node. That means what is happening in my PR interval? Normal. After that, one portion is getting excited through the muscle by the accessory pathway, means this will produce an initial delta wave, because after this, a portion of ventricular muscle is activated by this muscle by non-specialized conduction system. So I will have a delta wave. So if I have a short PR and delta, it is Kent. If I have a short PR, normal QRS, it is James. If you have a normal PR with the delta, it is Meheim. You understand these points? So it is all depends upon where your accessory bundle is getting conducted. So it is totally bypassing the AV node, and initial activation itself is through the muscle. You will have a short PR and delta. It is Kent. After, if James, the AV node is bypassed, there is no abnormal ventricular depolarization through the muscle. So QRS is normal. PR short, QRS normal, James. In Meheim, which is very rare, the PR interval is not shortened because your accessory bundle starts after the AV node. Then it connects to the muscle. But you will have a delta wave because this bundle is connecting to the muscle and activating the myocardium. Aberrantly, you will have the initial slur. So from ECG itself, if you understand this concept, looking at the ECG, you know there is an accessory pathway. You know what accessory pathway this is. Is that clear? So these are the three important accessory pathways you can easily diagnose by looking at the ECG. So you can see this accessory pathway. The problem is there is an accessory pathway here. So what complex, for example, I am now going to concentrate only on the Kent bundle. The Kent bundle is the one which is connecting the atrium to the ventricle here. Normal AV node is here. So what happens is my normal impulse, which is coming from the sinus node, one portion will go through the normal conduction system, which will get delayed through the AV node, and it will, as it going through, one portion will be going through the accessory bundle and reach the myocardium very early. So your QRS complex, because this portion of the myocardium, because this portion of the depolarization process is reaching the ventricle very fast, your PR interval is short. After this, once it is come to the ventricle, it is getting conducted very slowly because it is going to go through the muscle. That initial portion tells you the activation front which is coming through the accessory bundle. By the time it is slowly spreading, the impulse which is conducted through the normal system, after getting delayed at the AV node, gets rapidly conducted through the specialist conduction system that produce the initial sharp portion or the initial normal portion of QRS which is coming through the normal conduction system. So actually the WPW syndrome ECG complex is fusion complex of depolarization fronts coming through the accessory pathway and through the normal pathway. The initial portion of the QRS complex is rapidly reaching the ventricle, but then getting conducted slowly. That's why your PR interval is short, you will have initial delta wave. By the time it is spreading slowly here, the normal impulse after getting delayed at the AV node gets rapidly conducted through the special conduction system that produces the terminal sharp portion of the QRS complex. That is the difference between your bundle branch block and pre-excitation. In pre-excitation, the abnormal depolarization is happening initially, whereas in a bundle branch block, the abnormal depolarization happening at the last. That's why you have a terminal delay there, you have an initial delay there. So looking at the QRS itself, we know whether the activation fronts through the abnormal pathway is larger or through the normal pathway is larger, right? If I have a very short PR and a very large delta wave, my majority of impulse is coming through my accessory pathway. Whereas my PR interval is just short, I have a small delta wave. That means majority of my wave is coming through the normal pathway and small amount is coming through the accessory pathway. So this is actually the ERS complex you are looking at in WPW syndrome or the Kent pathway of short PR, initial delta, terminal narrow QRS is the fusion complex of two activation fronts which is coming through the accessory pathway and through the normal pathway. Is that clear? So this is how we derive the ECG and look at the ECG not only to diagnose it's a Kent bundle, but also to say whether the, for example, 100% activation front is coming from the sinus node, whether it is 75% through the accessory pathway and 25% through the normal pathway, or 75% through the normal pathway and 25% through the, I'm now looking at the short PR interval and the delta wave. Shorter the PR interval, larger the delta wave, 70% is going through the accessory pathway. Near normal PR interval, the small delta wave, 70% is going through the normal pathway. So this way you can decide. What is the importance? Why we have to break our heads at 7:30 p.m. today on Saturday about WPW syndrome? Right? Is because of its ability to produce a supraventricular and dangerous arrhythmias, which is life-threatening arrhythmias. So this is a fusion complex. As you can see that the activation fronts coming through the accessory pathway and also the actin pathway produces the short, the initial delta wave, and terminal QRS complex is so narrow, which is contributed by the spread of impulse through the normal conduction system. So what happens is in this short AV conduction, bizarre upstroke of QRS and the wide QRS because of the initiation of ventricular depolarization. The problem is it happens in 0.3 of the population. Risk of sudden death in 1 in 1000. Sudden death is due to atrial fibrillation with rapid ventricular contraction. Atrial fibrillation can happen even after one episode of the tachycardia. So what happens is there are two types of tachycardia in WPW syndrome. One is called orthodromic reciprocating tachycardia, by which I mean, for example, as far as the normal sinus impulse is going through, it will be going through, as we told you previously, it will be going through both the bundles, so it will have a normal QRS. But sometimes what will happen is, if there is a premature beat, let us imagine there is a atrial premature beat. What this atrial premature beat will do is, it will go through one pathway and it will not go, by the time the atrial premature beat comes, one pathway would have recovered, one pathway would not have recovered. For example, the sinus rhythm, both pathways are responsive, the impulse is traveling like this. Let us imagine I have a premature beat which has gone through the one pathway which has recovered, and it has not gone through one pathway. It will what to do is the impulse which is going through the one pathway will come back through the other pathway and form a re-entry circuit. So this is a re-entry tachycardia or a reciprocating tachycardia. So if we have a premature beat there, let us imagine it is going through the normal pathway. By the time the premature beat comes, the accessory pathway has not recovered from the previous sinus impulse. So when the premature beat comes, it will find the normal pathway responsive and the accessory pathway refractory. So what will do is, it will go through the normal pathway, and by the time it finds the tail end of the accessory pathway would have recovered. So what it will do, it will return back through the accessory pathway back to the atrium and start circuiting like that. So this is called re-entry phenomenon or reciprocating tachycardia. So it is a premature beat which precipitates this re-entry tachycardia of a rapid re-entry circuit, which the heart rate goes to 170 or 180 or 200 per minute. So whenever my anterograde conduction is through the normal pathway, if it is going to be normal pathway, subsequently it is going to go through the normal conduction system. So my tachycardia will have a narrow QRS complex because my anterograde conduction is through the normal pathway, retrograde conduction is through the accessory pathway. So here the supraventricular tachycardia can be a narrow QRS complex tachycardia, which is called orthodromic tachycardia. I can say it here. This is orthodromic tachycardia, where my re-entry circuit, the anterograde conduction is coming through the normal pathway to produce the depolarization of the ventricle through the intact bundle, and it is getting back through the accessory pathway and forming the re-entry circuit which precipitates the tachycardia. So in orthodromic tachycardia, the QRS complex is narrow. So you can have an SVT with a narrow QRS complex tachycardia, which is most often the case, and most often it can be cured with medicines and so on. It is not very dangerous. But you can see it here. The normal conduction is through the normal pathway. Retrograde is going through the accessory pathway. Your QRS complex is narrow QRS complex tachycardia, which is called orthodromic tachycardia. So you can see that tachycardia, it's a narrow QRS complex tachycardia. Tachycardia is there, but your QRS complex is narrow. That means the impulse is coming to the ventricle through the normal conduction system. The QRS is not widened. So this is the orthodromic tachycardia. Whereas in certain situation, the premature beat will find the accessory pathway responsive and the normal pathway refractory. So anterogradely it will conducted through the accessory bundle, and retrogradely will go through the atrium through the normal bundle. So the normal conduction system. So because here, what is the primary problem here? Primary advantage here. Because your anterograde conduction is coming through the AV node will check the impulse. It will not allow the rapid impulse to the ventricle, isn't it? So there is a protection of your AV node. Although your re-entry circuit is coming, AV node will not conduct more than 200 impulses to the ventricle. So the AV node will limit the amount of impulse which is going through the ventricle. Whereas when you have this tachycardia where the anterograde conduction is going through the normal, through the accessory pathway do not have the AV node, do not have any mechanism by which it can block the rapid supraventricular impulse. So if the atrial fibrillation is happening at 400 per minute, all the 400 impulse it will transmit to the ventricle. You understand what I am saying? So because of that, the ventricular response is so rapid, the patient will go for a sudden death. This is called antidromic tachycardia. Antidromic is anterograde conduction through the accessory pathway, retrograde conduction is through the normal pathway. Because the anterograde conduction, now you can see, because anterograde conduction is through the accessory bundle, here what happens to the ventricular depolarization now? Through the accessory pathway, if it is connecting to the ventricle, the depolarization is going to go through the muscle, isn't it? The anterograde conduction or the ventricular depolarization is going to go through the muscle. Then what will happen to the ventricular tachycardia QRS complex? It will be wide. So the WPW syndrome can produce a white QRS complex tachycardia also if the anterograde conduction is through the accessory pathway and retrograde conduction is through the normal pathway. This is the most dangerous tachycardia, because whatever the impulse which is produced by the atrium will be just transmitted to the ventricle. So the ventricle is not protected by the AV node. So this is where you have the sudden death. When the patient has got atrial fibrillation, 400 per minute, 400 impulse to the ventricle, ventricle will defibrillate. Ventricle will fibrillate and the patient will have a sudden death. So this is, you have the white QRS complex tachycardia. You can see that here now. So this is a tachycardia due to anterograde pathway. See the rate. It is less than 1 small square. That means what is the rate? More than 300. So intact AV node will not conduct this amount of impulse to the ventricle. So whenever the tachycardic rate is more than 300, you know this impulse to the ventricle is not coming through the AV node. It is coming through an accessory pathway. And you see the QRS. QRS is wide. See the QRS? QRS is wide because it is coming through the accessory pathway. So this type of rapid supraventricular impulse, whenever you see this, you immediately know it is an atrial fibrillation with antidromic tachycardia through the accessory pathway. The immediate thing is a DC shock and subsequent treatment. So here you must avoid 3 important drugs: digoxin, verapamil and adenosine, which you commonly give for a supraventricular tachycardia. So whenever you suspect an antidromic tachycardia, these 3 drugs should not be given at all, because this is going to totally block your AV node. And whatever the small impulses which are coming through the AV node, everything is going to come through the accessory pathway and patient will die immediately. It's a very, very easy way to send the patient up. So in this situation, if you give digoxin and verapamil, that's it. So these are the situation you will never give these 3 drugs when you suspect an antidromic tachycardia. One episode of supraventricular tachycardia, whether it is an antidromic or orthodromic, is an indication for radiofrequency ablation in WPW syndrome. Even one episode of any tachycardia, be it narrow QRS complex also, it's an episode, it's an indication, the permanent cure to the WPW syndrome, where they go through the vein and they reach the myocardium and map the myocardium to see where the accessory pathway is. Then through the radiofrequency energy, they will completely block this accessory pathway. So no longer the impulse will come through this accessory pathway. So every impulse will come through the normal pathway. The PR interval gets normalized. Your delta wave will disappear after radiofrequency ablation. So this is the treatment of choice whenever you have even a single episode of documented tachycardia due to WPW syndrome.